I know this is right before the holiday weekend, so thanks for attending lecture. Some housekeeping items before we get started on the content for this evening. I will be grading the fill in the blank questions from quiz 4 over the course of the next couple of days. So we'll go over the answers to that quiz during our class session on Tuesday. Next Tuesday is the last chapter of the text. Chapter 14 is on the future of healthcare service delivery. So that will be the last chapter that we'll cover, the first half on Tuesday, the second half on Thursday. And then there will be a quiz on April the 26th. That'll be the last quiz of the session, and that will be during our normal class session to meet. And then on April the 28th, we'll do a review session for the final exam, which will be on May the 3rd. So we are quickly winding down the semester. If you have any questions, obviously feel free to reach out, but I will be going through quiz 4 and grading those fill in the blanks over the next few days. Any questions before we move on? All right. So tonight we're going to talk about health policy. And for those of you that will take 464 on ethical, legal, and financial issues in healthcare, it's a little deeper dive into some of the policies that we'll discuss this evening. This is an overview historically of healthcare policies that have shaped the youth delivery system to date. Material's a little dense, but I think hopefully we'll make it approachable here, and you'll, at a minimum, be able to recognize some of these regulations when you come into contact with them in the future. So health policy is a foundation for a lot of the regulatory elements in the delivery system. So this evening, we'll cover information to meet 3 key objectives. The first is to define health policy, exactly what it is, and explore how the features of different regulations have impacted the delivery system. And then describe the development of legislative policy. So how is policy put in place with all of the different steps that are required in order for something to become law. It's kind of miraculous that anything ever gets accomplished, and that there's forward motion. There's lots of steps from the conception of a policy to when it's actually implemented. And then we'll provide an outlook for the future of U.S. health policy and some reforms that we might be seeing in the future related to healthcare. So first, we discussed multiple times during the duration of the semester, the United States does not have a centrally controlled system of healthcare delivery. So the government is not the overseer of healthcare in the United States. But we do have a history of federal, state, and local government when it comes to the development of healthcare policy and the role of each of the branches of government in the delivery system. So first, what is policy? From a public perspective, policies are authoritative decisions that are made in the legislative, executive, or judicial branches of government. And if you think back to your 5th grade history and civics classes, the legislative branch is congressional. They pass laws, executive branch implements the laws, and the judicial branch reviews any court cases related to how those laws are implemented. So the public policies that are put into place are intended to direct or influence the actions, behaviors, or decisions of others. So that's general public policy in its role. For health policies are public policies that pertain to or influence the pursuit of health care. And in the text, there's a definition provided for health policy. Health policy can be defined as the aggregate of principles that distribute resources, services, and political influences that impact the health of the population. So that's a lot of verbiage, but there are different aspects of care. So the resources needed, so that's everything from the facilities, healthcare providers, the actual medical equipment, all of those things, to the services that are provided. And then political influence plays a large role in how health policies impact a population. A lot of the policies we'll discuss this evening are the result of things that have occurred in a social context, and then policy has been developed to address those things. So there are different forms of health policies, and they're often a byproduct of public social policies that have been enacted by the government. Health policies pertain to healthcare at all levels. This includes the production, provision, and financing of healthcare services. So it's a large umbrella of all of the things that we have talked about from a service line and provider type. So long-term care, licensing boards, certifications of hospitals, all of those fall under an umbrella of health policy. So policies can affect groups or classes of individuals, such as physicians, the poor, the elderly, or children. So we talked a lot about special needs populations. Policies are often developed around the needs of those classes. And then they can also affect organizations. So medical schools, health management organizations, nursing homes, medical technology producers, which would include pharmaceutical companies, and healthcare employers. So what are the different types of tools under the umbrella of health policy? So there are regulatory tools. The regulatory tools call on the government to prescribe and control the behavior of a particular targeted group by monitoring the group and imposing sanctions if it fails to comply. Can anyone think of an example of a regulatory tool? The text talks about a couple. So you can either unmute and answer, or if you'd prefer to type in the chat, you can do that as well. What's an example of a regulatory tool? So federally funded organizations, yeah, the organization itself isn't necessarily regulatory, but the standards or the way that they appropriate care can be regulatory. So the regulation of insurance companies, yes, so that's left to each individual state. Each state has an insurance commission, and the role of that commission is to make sure that health insurers, or any insurer for that matter, doesn't put premiums or practices into place that are unfair to consumers. Doctors have to have a license in order to practice medicine? Yes. So that would be a regulatory tool, licensure requirements, certification requirements, even our academic institutions. So if you think about what curriculum is included as part of a graduate level public health course study, all of that is determined by regulatory tools or regulatory requirements. Good. The second type of tool is allocative tools, and these involve the direct provision of income, services, or groups to a good or individuals or organizations. So there are two types of allocative tools. There's a distributive type and a redistributive type. Redistributive spreads benefits throughout society. Distributive spreads benefits throughout society. Redistributive obtains resources from one group and gives it to another. And it's typically under the distributive type of allocative tool that there will be the most pushback or resistance. So the example that the text gives is a system that often creates visible beneficiaries and payers. So redistributive policies, Medicaid, for example, will take public health or public tax funds and redistribute them to those that are poor in the form of free healthcare coverage. So any policies that are redistributive in nature tend to be polarizing and gain a lot of attention. So again, you can see the two main types there of allocative tools, and health policy can become politically charged. You don't have to be super informed in current events to know that this is an ever-evolving thing. So obviously, when the ACA was implemented in 2010, there was a lot of politically charged discussion around the policies that it would implement in the healthcare arena. Recently, there have been lots of state actions related to health policy for abortion services. So it's not uncommon, it's pretty standard for health policies to be politically charged in nature. So we've talked about the different forms of policies in the form of laws or statutes or certification requirements, the regulatory tools, the allocative tools, all of that comprises and explains the definition of exactly how health policy is implemented in the U.S. healthcare delivery system. The next is to talk about the principal features of U.S. policy as it pertains to healthcare. So features of U.S. healthcare interact or influence the development and evolution of health policy. And we're going to look at each of these areas in more detail and how they define the principal features of our regulatory health policy systems. So the government functions as a subsidiary to the private sector. It's fragmented, incremental, and piecemeal reforms, pluralistic and interest group politics, decentralized roles of the state, impact of presidential leadership, and then finally research and policy development. The first is government as a subsidiary to the private sector. So what does that mean? The government is not, because we don't have a centralized healthcare system, is not the overseer of healthcare. We look to the private sector to actually function as the administrator of our healthcare services, and that healthcare isn't seen as a right of citizenship or a primary responsibility of government. So that's one of the things that differentiates the United States from other developed countries in the world. Healthcare here is not seen as a right, in that everybody has the same access and the same coverage and the same ability to obtain care. Americans prefer market solutions over government intervention. So that very philosophical belief that government should play a smaller role in how much it intervenes, and that free market should prevail in most of our public spaces. And then the complexity of healthcare makes it difficult for many consumers to make informed decisions. So we've had improvements through health policy in what have to be included in documents, like the explanation of plan or the summary of coverage, how those things have to be written. But it is very difficult when you go to shop for a car, for example. You know all of the features that car has. You're able to compare the same make and model of vehicle at one dealership compared to another. You can decide what you want your car payment to be and only shop for vehicles that are in that price range. All of that is easily accessible and easy to understand. That's not necessarily the same for healthcare insurance. When you're going to compare plans, a lot of tools are now available to do that type of comparison, but still, if you don't understand basic principles of how health insurance works, which is one of the things that I really hope that you're able to walk away from this course with an understanding of, is how cost share works. How do you look at a policy and know what you're going to have to pay out of pocket for that insurance coverage plan? So I think even when the ACA was being debated in Congress, I think Americans equated the Affordable Care Act with the concept that everybody would have health insurance, everyone would have affordable health insurance, and everyone would be able to continue to see the same providers that they had already established care with, and there wouldn't be any obstacles or barriers. And that's not the case. So a lot of people think if they have insurance, then that means that they go to the doctor and they don't have to incur any additional out-of-pocket expense from their premium. And that's just not how our system works. So, and when you're looking at spaces like long-term care, it gets even more complex. So we'll talk a bit more about this as the lecture goes on, but government as a subsidiary to the private sector makes it really difficult for consumers to understand and make informed decisions when they're purchasing health insurance or looking for healthcare services. So government's grown incrementally in response to perceived problems and negative consequences. A lot of this is accomplished through different agencies and oversight committees, but several years ago, I'm going to say it was like in the 80s, I should remember this, but there was a occurrence where someone tampered with Tylenol bottles, and there were several deaths in relation to them tampering with the medication. I believe they put arsenic in the medication. And as a result of that occurrence, additional regulation was put in place about seals and how containers had to be manufactured for over-the-counter medications. So a lot of times when there's a lot of constituents pushing for resolution to a specific problem or negative consequence, the government will intervene agency or regulatory health policy to address those concerns. Policy interventions begin with the identification of the problem where markets fail or do not function well. So again, not super proactive in the way that our health policies are structured. We tend to be more reactive in how things are addressed in our healthcare space when it comes to policy decisions and information. So some of the examples that are discussed in the text in response to problems are escalating costs, or bureaucratic red tape or inflexibility, excessive regulation, irrational paperwork, arbitrary and sometimes conflicting public directives. So the government really fills in the gap that exists when there is spending for healthcare that occurs as a result of what's happening in the private sector. So healthcare coverage is viewed as a privilege, and then government is left, again, to fill in the gaps for the most vulnerable populations or the uninsured population. So another feature of our U.S. health policy is it's fragmented, incremental, and piecemeal in reform efforts. So the mix of government and private insurance results in a complex and fragmented system of healthcare financing, in which the employed are insured by voluntary insurance through contributions that they or their employer pay. One of the things that we're starting to see now in the private insurance sector through employer-sponsored plans is something that's referred to as reference-based pricing. And in a reference-based pricing model, those programs are sometimes administered through insurance companies that have their own commercial plans. So it's difficult for providers to sometimes differentiate between a regular commercial policy that's sponsored by an insurer and a reference-based pricing plan that's administered by that same insurer, but it's not actually sponsored through the company. And what reference-based pricing does is it uses a percentage of Medicare as the means for determining reimbursement. So there's not a contract between the insurance company, the healthcare provider. And why that becomes a problem is services are negotiated ad hoc. So a lot of times providers, like I said, it's difficult for them to identify those plans based on their insurance card or the patient's insurance card. And they receive a significant decrease in the amount of reimbursement that they receive for the services that they're providing. Sometimes it doesn't even cost to render the care. Well, why do programs like that exist? Because cost every year increases for commercial coverage. Employers are looking for a way to mitigate the increase. So one of the ways that they do that is by purchasing this type of plan. And as providers become more familiar with the dynamic of that type of product, then they opt not to accept it. And when they opt not to accept it, then the employee who has that insurance, again, it's not a true insurance policy from a traditional definition, when they go to receive care, where they can go is restrictive. So, there's this gamesmanship that happens kind of behind the scenes in the industry, and it's a result of this fragmented relationship between government and private insurance. So the elderly, we've talked about the different parts of Medicare and Medigap that is created and covered through MedAdvantage Part C type plans, but Medicare is financed by Social Security tax revenues, and over the years, the cost of caring for elderly patients is also increasing. So there's a constant supply and demand dynamic between the cost of care and the need to access it. So the poor, another way that it's fragmented and incremental, are covered through Medicaid via federal, state, and local revenues. Under the ACA, states had the option to expand Medicaid, but only 33 out of the 50 states made the decision to actually expand that program. So there's still a disconnect between the way that Medicaid programs are funded through federal and state revenues and who has access to enrollment in those plans. Some of these populations, we talked about those extensively, such as veterans, Native Americans, members of our armed services, and those that are covered directly by the federal government. So the Affordable Care Act was a major reform to achieve universal coverage, and while it did increase the number of people that had health insurance, it wasn't completely successful in reducing the population that was uninsured completely. There are still Americans that do not have any health care coverage. So pluralistic and interest group politics, health policies have been based on interest groups and incremental policies. Innovative, non-incremental policies are resisted because the measures increase threats to interest groups. So interest groups have lobbyists that contribute to campaigns to help solidify that policies that are passed align with whatever interests that their group is looking to protect. So public community members, those that are in legislative committees with jurisdiction in a policy domain, executive branch agencies are responsible for implementing the public policies in a public domain, and then interest groups in a private domain. That's an important delineation to understand. So the membership of the policy community has included all branches, so legislative, judicial, and executive branch agencies. And they're responsible for implementing policies in the public domain. So how rules are developed, and we'll get a little bit more into detail in legislative policy and how it is passed and what processes it goes through in order to become law. But all of these political influences impact the way our policy is not only written but implemented into the public space. So you'll see some examples of interest groups listed here on the slide. The AMA, the AARP, and the AHA are all examples of interest groups that work to protect the members of those different professional organizations. They use a combination and concentration of their resources in order to make sure that their particular items are protected when it comes to what health policy is put into place. And the last category is employers. So their concerns about healthcare benefits for their employees, dependents, and retirees, a lot of that is cost-driven. So most small business will oppose mandates of coverage because of the cost. This seems to be counterintuitive to me, because when you think about, and from an employer perspective, if your employees are not healthy and they don't have access to healthcare services, how well are they going to be able to fulfill their responsibilities for your company? In order to be able to do any job, you have to have the health necessary to do it. So some larger companies, JP Morgan Chase, I think Amazon as well, have developed their own insurance companies to oppose some of the things that are happening in the commercial private sector spectrum for healthcare. But it seems counterintuitive for business to impose mandates that require coverage for their employees. And if we think back to the very beginning, or close to the beginning of the course, we talked about health insurance became something that was implemented as a benefit during World War II to employees to help offset the decline in compensation and pay for their jobs. So it seems like we've almost done a 180 from a social perspective in how employers view healthcare coverage for their employees. The other part of this, so if you want to advocate on the other side of the coin, is commercial costs for care have consistently increased over the years. So there's a cost shift. When Medicare and Medicaid reimbursement drops, in order to make up that deficit, because those facilities and providers that render care, they have to be able to financially sustain themselves in order to continue their mission to serve the healthcare needs of communities. So when Medicare and Medicare reimbursement drops, then that cost shifts, and it shifts to the commercial consumer. So while premiums for Medicare have gone up as well, they've not increased in the same amounts that commercial has. So it is costly when we look at how costs have shifted as a result of decline in reimbursement under the government payer programs. And then the uninsured population also contributes to that, because if there is no insurance coverage, then the ability of an individual to be able to pay a large amount for medical expenses, it declines. So, if you're not able to afford health insurance, but you don't qualify for government programs, are you going to be able to afford an expensive medical bill? Probably not. So then that turns into care that the facility or the provider is not reimbursed for. So it's a shell game of shifting dollars around to different product lines between government and commercial. For consumer groups, the interests of consumers are not always uniform. So consumers don't have sufficient financial means to organize and advocate for their own best interests. So, individual Americans don't all have the same healthcare needs necessarily, and they don't all view the things that we've talked about, cost and quality and access, from the same perspective. So we have seen some ability to kind of mobilize, but there is a lot of diversity in what each individual American expects from the healthcare system, and their willingness to pay higher taxes or higher premiums for their own insurance. Manufacturers of technology. So we had an entire chapter dedicated to technology, and pharmaceuticals fall under this category. So health policy concerns regarding medical technology include its role in health costs and its health benefits to people, although not always. So, we talked about the cultural perspective that we want innovation and new technology integrated into our healthcare, but we don't always have a great way of analyzing those resources to make sure that they're efficacious and the health outcomes that they are expected to provide. So current U.S. policy for medical technology is the interest of policymakers developing cost-saving technology and expanding its access. So alliances are diverse interest groups that may create. There are diverse interest groups that may create alliances among themselves and with members of the legislative body to protect and enhance the interests of those benefiting from government programs. So each member of the alliance receives benefits from their efforts, and this is a means of combating kind of the interest groups that we talked about previously. So the states play a decentralized role in that each state has their own autonomy in the way that they manage some of the healthcare programs. So when we're looking at principal features of policy, states' rights play a unique and important role. So each state will develop and implement health policies involving financial support for the poor and disabled. So that's through the Medicaid and CHIP program, the Children's Health Insurance Program. Quality assurance, practitioner, and facility oversight. So the states are responsible for licensing hospitals, long-term care facilities, healthcare providers, and practitioners. All of that falls under the umbrella of the state's responsibilities. And then regulation of healthcare costs and insurance carriers. So that's done through the State Insurance Commission. Health personnel training that's conducted through different state agencies. And then the authorization of local government health services, so our departments of health. All of those are different entities under each state's control and function. States have broad legal authority to regulate the healthcare system. So the state can do several things from a regulatory role. License and regulate healthcare facilities and professionals, restrict the content, marketing, and price of health insurance, set and enforce environmental quality standards, and enact controls on healthcare costs. So all of those different functions are controlled by and overseen by the state government. I think the pandemic really kind of brought this into perspective when we were looking at the distribution of COVID-19 vaccines and different requirements as far as mask mandates and which businesses could be opened or closed. All of that really came into focus as far as how each state approached it differently. West Virginia was viewed as kind of a champion of vaccine distribution early on, and the methods that they were using to identify which populations would have access to the vaccine first and how they would be able to obtain it, and setting up vaccination sites and all of that. So we really kind of had a unique example through the pandemic of how health policies and rules are different from one state to the next. States finance much of the healthcare for the poor. Most incremental policy actions originate at a state level, and there are several state-initiated programs that address vulnerable populations. Some argue that there's too much state control over health policy decisions, and that some of these functions would be better under the federal government, or even at a local level. So another principal feature of U.S. health policy is the impact of presidential leadership. So presidential leadership has led to major changes in health policies. Presidents can influence the outcome of what legislation is passed through compromise. So in 1965, we had Lyndon Johnson, who was able to pass the Medicare and Medicaid Act. That was the first really key health policy in the country that had overarching and long-lasting impact. And then Harry Truman would pass the Hill-Burton Hospital Construction Act, which we talked about, led to multiple hospitals being built across the country, and the escalation of national health expenditures as a result of increased access because of hospitals being constructed. And then in 2010, Barack Obama lobbied for the passage of the Affordable Care Act. So influences that health policies have through documentation, analysis, and prescription are impacted by research and policy development. So from a documentation requirement, it's the gathering, cataloging, and correlating of facts about the state of the world that policymakers face. So in order to develop policy, there has to be a fact-finding mission that takes place to gather the data that's needed in order to make policy decisions. And then from the analysis function, there's a program evaluation of outcomes through demonstration of projects intended to provide a factual basis for determining the feasibility, the efficacy, or the practicality of a policy intervention. So once you have the facts about a particular set of circumstances that you intend to address by implementing a policy, the analysis portion really projects, will that policy have the outcome that's intended? And then prescription demonstrates whether a particular course of action being contemplated by policymakers leads to an undesirable or unexpected consequence. So analysis, will we accomplish what we intend to by passing the policy? Prescription is, will we do additional harm? Is there a risk of this policy having an unintended or undesirable consequence if it's implemented? So there's lots of different steps that have to take place in order for a health policy in the United States to make it through the entire cycle. The policy cycle involves both private and public sectors, including multiple levels of the government. And the cycle is defined by 5 key components. The first is issue raising. Second is policy design. Third is building of public support. Fourth is legislative decision making and building of policy support. And then the fifth is actual policy implementation. So these activities are shared by Congress and interest groups. So the legislative process is required in order for a policy to be put in place. So these are all of the different steps that take place before a bill becomes a law. So we've all probably heard the Schoolhouse Rock song that's been around for years and years about how a bill becomes law. So first introduced in the House of Representatives, and then assigned to a committee by the Speaker. Once it's assigned to a committee, it's then reassigned to a subcommittee. And then it is sent to agencies to hold hearings, which are referred to as markups, and get the testimony and possible amendments on the bill. The committees and subcommittees may recommend, not recommend, or table the bill, so the bill can die in committee. The full House will hear the bill, and then they will, they can further amend it upon hearing. If it's approved, then it's sent to the Senate. The Senate follows the same steps as the House as far as it's assigned to a subcommittee. There's agency hearings, amendments, etc. So if there's any amendments added to the bill in the Senate, then it has to go back to the House again for approval. After the bill is passed in both the House and the Senate in identical form, then it goes to the President for signature. If the President signs the legislation, then it becomes a law. There's a couple of different things that can happen when it goes to the President. You can veto it, you can pocket veto it, which is by not making a decision to sign or veto, depending on where they are in the legislative session, it can be pocket vetoed. So once legislation is signed into law, that's only the beginning, really, of the process. It's then forwarded to the appropriate agency for implementation. The new regulation is posted in the Federal Register. If you are ever having difficulty sleeping at night and you need something to help you, read the Federal Register and you will no longer have insomnia. It's very, very dry reading. Hearings are held to see how the law will be implemented, and then the bureaucracy publishes, gathers comments, and rewrites the regulation. And then the program goes to 50 states for enabling the legislation if that's appropriate. And local interests will begin a new political process to shape the final outcome of the law. So given all of those different steps and all of the places that a bill can die or be vetoed or amended, it is fairly miraculous that we have had some of the major healthcare reforms like Medicare and Medicaid, like the Affordable Care Act, over the years. The text talks about the different things that have to kind of align in order for that to happen. So some of those things that we talked about that shape the principles of U.S. health policy are key in all of those steps, agreeing for something to become law in the healthcare delivery system. So there have been multiple critical policy issues that have been addressed or need to be addressed. A lot of these, spoiler alert, we have talked about throughout the course. So you're going to hear that same theme again. On this side alone, you've got access, cost, and quality. So that is a reoccurring theme. So access to care includes access to providers, public financing, access for the elderly, minorities, rural areas, so all of the special needs populations, access for low-income individuals, or access for those that use smoking or tobacco products. Cost containment has been an ongoing issue following the implementation of the Hill-Burton Act, when all of those hospitals were constructed and access increased and expenditures drastically went up. So cost containment continues to be one of the key policy issues that we talk about. Quality of care, how do you measure quality of care? How do you incentivize quality of care? How do you change the dynamic from a fee-for-service model to a value-based model? Mental health and access to services, providers, all of those are key critical policy issues. So access, we spent a lot of time talking about this in the last couple of weeks. So government policies are enacted to resolve or prevent deficiencies in healthcare delivery. So it's important that we improve access to care by expanding insurance coverage. So in both of the documentaries that we watched this semester, one of the key solutions to the problems that were identified in deficiencies in our current system were related to expanding insurance coverage. Changing the reimbursement from a retrospective to a prospective model, so PPS on the facility side, RBRBS on the provider side, and then the different clinical practice guidelines and the role of the AHRQ, CMS and accountable care organizations have played a key role in helping look at quality of care. So the goal when we're looking at access is really to expand care to the most needy and underserved populations in our country. Providers, so this not only is the supply of physicians, so making sure in rural communities especially that there are practicing providers, but also entrance to the medical profession is influenced by government assistance and grants. So how many doctors each year are integrated into the system. Policy helps to ensure that there are enough providers and that they're in geographically distributed across the country. Obviously, rural areas are where we have the most need. So policy has expanded to include legislation supporting rural health clinics, so RHCs. National Health Service Corp was implemented to help integrate providers into communities where there were deficiencies. Student assistance programs for emergency medical services, and then the establishment of community health centers in inner cities and rural towns. All of those things have taken place as a result of policy addressing needs. Public financing. So again, largely we're looking to help vulnerable groups obtain health care and make sure that there isn't an adequate access. That continues to be a problem. Policies since the 80s have focused on narrowly defined elements of the delivery system. And our ever-growing elderly population, so there's two main concerns when we're looking at Medicare policy. Spending has to be restrained to keep the program viable, but it also has to be comprehensive and adding the services that aren't currently covered or adequate. So again, kind of diametric opposing things there that really have to align in order for access for the elderly to be addressed. Access for minorities. So minorities are more likely than whites to face access problems. Low-income minority status and cultural habits will cause access problems. So cultural beliefs and stances on when care should be accessed, how it should be accessed, where it should be accessed, all impact access. Policies should encourage sensitivity programs to the special needs of minorities and deliveries of services to areas populated by minorities. So providers nationwide are required to complete, in order to maintain their credentialing with health insurance carriers, cultural competencies. So that has been integrated, again, as a result of changes in policy. Rural communities, we spent a good deal of time talking about this when we looked at special needs populations, but making care available to residents is difficult in rural communities. Most healthcare organizations are established in more urban communities. There have been programs to create incentives for permanent practices in rural areas, and those need to be expanded and are desperately needed when we're looking at deficiencies and inconsistencies in access. Low-income mothers and their children have problems accessing the healthcare system. CHIP was put into place as a result of needing to address this critical need. So federal funds with some state flexibility have funded the Children's Health Insurance Program to make sure that expectant mothers and children have access to care. The age threshold for CHIP has expanded over time. And then when we look at those that use smoking and tobacco products, so lung cancer is the leading cause of death from cancer in the United States. The statistic, I think, in the text is 480,000 people a year perish as a result of a lung cancer diagnosis. So IOMs are needed. I forget what IOMs is. Hold on. They published the Ending the Tobacco Problem, a blueprint for the nation. And as part of that publication, they identified the need to reduce the number of people in the population that utilize tobacco products. Institute of Medicine, as I don't know, I blanked there for a minute. So the Institute of Medicine released a report ending tobacco use, and the stated goal was to reduce smoking rates in the United States. This goal was set to be achieved through a two-pronged strategy that strengthened and fully implemented traditional tobacco control measures and modified regulatory landscape to permit policy innovation. It was done partially through the way those products are taxed and a control strategy that the CDC recommended in providing funding to develop programs. California has had a successful tobacco control program that has served somewhat as a model. And then there have been nationwide campaigns. I'm sure you've seen the Truth campaign that's intended to target youth, as well as other campaigns that are sponsored by the American Cancer Society, the American Heart Association, and the American Lung Association. Cost containment, again, we spent an entire chapter talking about access, cost, and quality. So the strengths of the U.S. healthcare system also contribute to its weakness. So our innovation, our desire to have research and development be part of our healthcare landscape also has led to increase in cost to render care. So the United States has the latest technology. We have well-trained specialists, but we also have the most expensive means of providing healthcare in the world. The National Health Planning and Resource Development Act of 1974, it became law in 75, marked the transition from an improvement of access to cost containment as the principal theme in federal health policy. So again, Hill-Burton was focused on access with all the constructions of hospitals across the country. And then in 74, 75, it shifted to not being policy not being predominantly focused on access, but looking more at cost. Major corporations are aggressively pursuing methods to restrain the growth of health insurance costs for their employees. Again, I talked about JP Morgan Chase is one of those companies, but they look at developing and implementing their own health insurance programs to fund care for their employees as a result of the escalation in costs for commercial insurance plans. And then along with access and cost is quality of care. The Healthcare Quality Act of '86 mandated the collection of national data on legal actions against healthcare providers. This information allows people to know actions brought against physicians in their own states. It's intended for consumers to be able to make more informed decisions about who they go to for care. The Agency for Healthcare Research and Quality was developed, and its goal is to conduct and support research on outcomes, effectiveness, and appropriateness of healthcare services and procedures. And it funds funds patient outcome research teams that focus on certain medical conditions. So there are 4 elements that really are used to determine medical treatment effectiveness. It's research in that vein, and then development of databases, development of clinical guidelines, and the dissemination of the research findings and clinical guidelines. All of that helps to kind of construct best practice standards and clinical practice guidelines. So AHRQ does focus on improving the quality of care. Health information technology initiatives have been key, especially with the implementation of EHRs. We also have the ability to process and analyze large amounts of data now in ways that we previously didn't. That was one of the concerns when EHRs was first implemented, is would the provider no longer have the same independence and autonomy in treatment decision-making that they had prior as a result of more strict guidelines or utilization management processes being put in place when we're looking at the analysis of different effectiveness in treatment protocol. Mental health policy. So this has taken center stage more recently than it historically has in the past when we look at the U.S. healthcare delivery system. But there are a variety of areas pertaining to people with a diagnosis of mental health conditions. So we talked about the evolution from asylums being the main course of treatment and therapy for those with mental health conditions in 1843, and the poor conditions that those facilities had that housed those patients, and then the development of mental hygiene and deinstitutionalizing the mental health care resources that were available in 1908, and then Action for Mental Health in 1961. Again, that would have been during the Kennedy administration, and President Kennedy did have a sister that suffered from a mental health condition. And the CMCH Act amendments of 1975 all have kind of evolved and pushed mental health forward in the way that we address the care needs of this population. In 1961, the Joint Commission on Mental Health published the Action for Mental Health, which recommended community clinics take on the burden of prevention and early intervention in mental illness. In addition to those programs, we've also had the Action for Mental Health, community support programs. In the 80s, there were programs that helped mentally ill patients regain benefits, the ADA, and then in 2011, the National Prevention Strategy. So deinstitutionalization has led to many seriously mentally ill individuals being homeless or in prison, and it may be attributable to the lack of funding for the community support groups that are needed in order to address the care needs and concerns of those with mental health illness. And there's also a shortage of mental health providers. So public policy has shifted its focus to support for addiction rehabilitation programs, to improve mental health safety nets, and then also to address the deficiencies again in the amount of mental health providers that we have that are able to provide care. So when we look at national health care reform, there have been some landmark statutes, obviously the ACA being one of those. We just celebrated the 12-year anniversary at the end of March of the Affordable Care Act being signed into law. And then there are three real challenges that full implementation of the ACA and what it continues to face. So it's the option for states to expand Medicaid. Originally, the ACA required expansion in every state, but a Supreme Court decision changed that requirement and made it optional for states to implement the expansion program. So there are still residents that are left in a coverage gap as a result of the program not being expanded in every state. Again, 33 out of 50 states did Medicaid expansion. Earning too much and too little at the same time. So it's possible for someone to qualify for Medicaid benefits and then have a promotion or increase in their income as a result of their employment, where they would no longer qualify for Medicaid, but the increase in their income would not offset the need that they have in order to continue to be able to have the same access to the programs that they had previously through their Medicaid benefit. Undocumented immigrants do not qualify for Medicaid and can't purchase marketplace insurance coverage, but they still access healthcare services when they have needs. So that accounts for a portion of our uninsured population. And there have been attempted repeals and other reforms in Congress. In 2017, that was the most recent one. Under President Trump's administration, there was the introduction of the American Health Care Act in the House of Representatives. The House narrowly passed the AHCA, but when the bill went to the Senate, there were several amendments, and those modifications to the bill didn't win the votes necessary in order to be passed. So Congress was not able to implement a comprehensive national healthcare reform bill in 2017. And many other reforms are still currently playing out in Congress and regulatory agencies and state government now. So all of these things can impact the landscape of our healthcare delivery system as we move forward into the future. So health policies are developed to serve the public interest. National healthcare is supported, but the idea of it being ran by the federal government is not preferred. And then the challenge in finding a balance between government provisions and control and a market to improve coverage and affordability are constant balancing act when we look at reform and new policy implementation. So a lot of information. I encourage you, there are several good podcasts and resources out there. If you find public health policy interesting, there's no shortage of changes in this arena. So take advantage of all the information that's out there because it does impact the day-to-day job responsibilities and functions throughout the healthcare system. So if that is what you intend to pursue as employment in the future, it would be beneficial to be familiar with what is happening in health policy. Any questions, comments, concerns as we close out chapter 13? Okay, so again, I will be going through and completing the grading on quiz 4. Next week, we will do the final chapter, chapter 14, and discuss the future of healthcare delivery service. And then we'll have quiz 5, the review for the final, and then the final on May 3rd. If you have any questions or need anything in the interim, you feel free to always email or text. All right, have a great weekend. Enjoy your Easter, and I will see you next week. Thanks, everyone.